Welcome to the Back Office Show, your peek behind the privacy curtain of successful healthcare operations. Get ready to learn how every bedpan is a potential gold mine in every staff meeting, a strategic summit. All right, I'm getting a little carried away here. Get ready to learn from the grandmasters of healthcare, their secrets for success. And now, let's welcome your host, Steve Shane.
Welcome to the Back Office Show. Firstly, I want to give a shout out to Clear and Stephanie from AHCA. Thank you for helping us, as well as Eli from Techies for helping put this podcast together. We couldn't do it without you. And I'd like to now welcome Mark Parkinson, who's very well known in the healthcare industry. Mark is somebody that everybody admires as a leader, the president of the American Healthcare Association. For now, things may change, as you'll hear within our conversation. Mark, welcome to the Back Office Show.
Hey, Steve, it's great to be here, and I really look forward to this.
Okay, and Mark, we know your time is limited. We appreciate that you're joining us here because you're probably not here to learn more. You're probably here to be giving us information. So we're here to listen, and I would love to learn more about you and get to know you personally as well as professionally, if that's okay.
Terrific. No, I'm happy to share anything and everything about my life, whatever you want.
Wow, it sounds like a therapy a little bit. I'm excited. Okay. So, Mark, as I mentioned, here at LTC Ally and here with our clients, we know you from American Healthcare Association, but we don't really know who Mark Parkinson is back from your earlier years. Can you give us a little background on growing up, what it was like, your exposure to leadership, your exposure to healthcare, and maybe some people or situations that may have influenced the way you advanced?
Sure. Well, I'll try to do this pretty quickly. So I grew up in Wichita, Kansas. I always had a love affair or kind of an enchantment with Washington, D.C. My family was involved in politics, and so I always had this really sort of view of D.C. that it was a place that I wanted to if not end up, that I wanted to visit. I actually came to Catholic University as a freshman because on a debate scholarship. This was clear back in 1975. But I transferred back to Wichita State. My family needed me back there. And so I went back to Wichita State, but I still had DC kind of on my mind. In between undergrad and law school, I came back to DC and I worked for a congressman from New York City. He represented the Upper East Side. His name was Bill Green, a tremendous person. It was a great experience, but I wanted to become a lawyer. So I went back to Kansas, went to law school there. Met my wife second day of law school. They say, don't have a romance when you're in law school. We had a romance. We got married our second year of law school. We lived in a mobile home in Lawrence, Kansas, and we were incredibly happy. We almost moved to DC then. I clerked for a law firm after my second year of law school. Stacy clerked for the GAO, but we wanted to practice law together. So we went back to Kansas. We opened up a law practice. We were having a blast with it. I was also in politics. I was a state senator when I happened to tour an assisted living facility. I thought it was a brilliant idea to have a residential way to take care of older folks. We decided to build a facility. One thing led to another, and we ended up quit practicing law. I quit politics, and we started building long-term care facilities. Our third facility was a nursing home, and you only, they say you only need one good idea in life, and my one good idea was that we built our nursing homes like we built our assisted living facilities. So they all had private rooms. They were all super nice, very upscale. And back in the late 90s and early 2000s, that was new and it really caught on. It was quite successful. We got bought out by Brookdale in 2006. That allowed me to get back into politics. By the most bizarre way possible, I ended up becoming the governor of Kansas. It was an incredible time and a great opportunity, and I thoroughly enjoyed it. When my time ended, the job happened to open up to run ACA, and I got recruited to come out here, and I've been out here for the last 14 years. Along the way, we've had 3 kids and now 2 grandkids, and thankfully, all 3 of those kids have settled in DC. So life is really, really good right now. I've been enamored with leadership principles and leadership books all along this journey. I've developed a very specific philosophy about running organizations and trying to help people. And there have been a lot of books and a lot of people along the way that have had a big influence, and I'm happy to talk about them if you'd like.
Yeah, that sounds so interesting. I mean, you took us on a time machine really, really quick, quite a couple of years, and a lot of frequent flyer miles you probably got between Kansas and DC along the conversation. So I just want to, something you said intrigued me in regards to your philosophy, in regards to leadership that you kind of applied throughout your career. But what is that philosophy that you're referring to?
Well, my leadership philosophy journey really started, like so many people, with the book, Jim Collins' book, Good to Great. That was the first book that I read that really had a huge influence on me in realizing that you could sort of strategically develop a way from going from good to great. That caused me to go back and read books like Stephen Covey's 7 Habits of Highly Successful People. And then my most recent journey has really led me to greatly admire a set of books by the Arbinger Institute. The leading book is called Leadership and Self-Deception. If I had to summarize my philosophy, it would be, and Claire and others that are listening to this are sick of hearing this because we talk about it all the time at ACA. My philosophy is that in order to succeed as an organization, you need to be driven by a mission. You need to be a mission-driven organization, and you need to hold yourself accountable to metrics. You need to measure everything that's important, align interest with those things that you're measuring, incentivize people to achieve them, reward them when they achieve them, and when they don't achieve them, get them off the bus and find people that can achieve them. So to me, it's all about mission and it's all about metrics, and the combination of those two, I think, very powerful concepts.
Amazing. Mission and metrics. It's so important to understand that everything has to be measurable and there has to be a vision and a goal from other healthcare associations, and not to put any down, but other associations, I should say. They're looking at membership and meetings and more members and more meetings. So it's really nice to hear that that is your philosophy, to look at metrics and make it measurable. And that way, I'm assuming the reason why you're so successful in your current position at ACA is because you're able to turn around to governing bodies and show them, here are the metrics of the steps that we've taken and the accomplishments that we've made. Instead of them hearing what they've seen maybe in the news of some disparaging story, you're able to hold real facts in front of them. And I'm sure that makes a big difference.
Yeah, I think that organizations that are driven by mission and metrics do well. And so if you look at the nursing home sector right now, there are a bunch of companies that are just doing exceptionally well. When you sit down and you talk with their leadership, and not just their leadership, people, the frontline people in their buildings, they will tell you what their mission is. And they will almost universally tell you that their mission is their employees and it's their residents. And third comes their financial returns. Their mission generally is not to make money. Their mission generally is to create jobs and do a great job at taking care of people. But it's not enough just to have a great mission. You also have to have an action plan. And the action plan typically is to have metrics that reflect those values. So to be constantly measuring employee engagement and satisfaction, to constantly be measuring resident satisfaction, to constantly be measuring things like rehospitalizations, census, net operating income, setting very specific goals around those, incentivizing the building leadership to achieve them by giving them more money when they do, but then also holding them accountable when they don't. Because one of the mistakes that leaders often make is they keep people in positions for too long that aren't able to meet the goals that they've set. So, whether it's running a church or a university or a law firm or a trade association or a nursing home company, people that have married mission and metrics do quite well.
And all those things that you mentioned are things that you actually did, basically. So I trust that you know that. And really, like you mentioned, it's all about working with people and how to hold people accountable and how to work best to have everybody produce. But I'm curious, being that you have, a resume with all these different kind of positions, from law to politics to healthcare, were there any challenges getting yourself and your mind accustomed to switching gears into healthcare? Were there any eye-opening moments where healthcare kind of looked a little different than you may have expected it from the outside? I know you said you operated one, so you really got down into it.
Yeah. Well, so Stacy and I, we've had 4 jobs, and we've done 3 of them together. So the 4 jobs are: we ran a law firm that we started. We had our own long-term care business. We were involved in public service. I became governor, and she was first lady. And then my fourth, and for the last 14 years, is running ACA. By far the hardest of those four, and it's not even close, was running nursing homes and assisted living buildings, owning a long-term care operation, which is what virtually all the listeners are in. That it is really, really hard. And as prepared as you think you might be to get into healthcare, there are always surprises. And every time we thought we sort of had things figured out and we'd kind of seen everything, then something other really weird or bizarre would happen, or there'd be some other surprise. Now, the great news is that there are surprises on the good side too. I mean, we had no idea when we got into long-term care the kind of relationships that we would develop with our staff and with our residents. Because we were small, the most number of buildings, we built 10 buildings, but the most that we ever owned and operated at one time was 6. So we were pretty darn small. We knew, certainly in the early days, we knew all of our employees, we knew all of our residents, we knew the families, and you would get really, really close to these people. And I some of my most meaningful memories in life are my memories with residents. So there are many, many good things about it, but it is super, super hard. The leadership principles of being mission driven and setting strategic plans and aligning people's interest and being super focused on employee engagement, they really apply across all settings. When I talk to people that are successful in long-term care, they tell me basically that they're doing those things. When I talk to people that are successful in whether it's the restaurant business or running churches or not-for-profits or whatever, they're also using those principles. So that's why I think that leadership books like Good to Great have been so incredibly popular, because they cross sector lines. But I will also tell you the easiest job I ever had was being governor. People are like, oh, that must have been really hard. Being a governor is an easy job. You have unlimited resources. You have unlimited resources. You can get anybody to return your call, get you any information that you need. You can be really bad at it and people will pretend like you're still good at it. That doesn't work in long-term care. So in fact,
don't you have people at a percentage of the population at least that just dislike you automatically? So, that's difficult.
That's true, I think, at the national level. In a smaller state like Kansas, and the time that I was governor was during the Great Recession, so we were all kind of pulling out of a really, really tough time. The state pretty well pulled together, and because I announced that I wasn't going to run again, that took all the politics out of my time as governor, and it was a terrific time.
Wow, it's really something that it's amazing that you feel like that was the easiest, but it really, like you said, it talks to healthcare operators to understand that number one, their job is as difficult as you mentioned, where there's constantly fires to put out, and when you think you've put one out, a new one pops up.
Yep.
But also knowing that there's somebody at ACA that understands that lives that, and breathes that as well, so you really recognize those challenges.
Well, I appreciate that. But if you're an administrator or a DON of a building, that is a really, really hard job. You're running a hospital, you're running a hotel, you're running a restaurant. You've got limited resources. You've got people coming at you from all different directions. It's really hard. And that's why it's so important that when we find great people in those positions, we really need to reward them and do everything we can to keep them in the sector.
So how did you, when you were interviewing or selecting the employees that would be on your team, I know I have a difficult time with making those judgment calls at an interview. What would you have looked for to find the people that were good, the people that you think would have a good potential, anything that others that are obviously any industry that are hiring could benefit from, just the way you may have analyzed that?
Yeah, and I mean, the first thing I have to confess is that this is not my strength, and I recognize that. And this will sound like a humble brag. It's not. I tend to see the good in people, and I think, I tend to make an argument in my mind that everybody can work out in this position. So I'm not particularly good at this. So I could give you people from our organization that are very good at selecting new employees. But I would say that my general view is that you need to interview people, I think, longer than they are typically interviewed. You need to, anybody can do a pretty nice job, in an hour, but if you can see them in several different settings, I think that's very helpful. I think the most important quality that I look for, and you can just see the way people interact with people, is humility. I want somebody that's humble, that's not going to be taking credit for everything, that's willing to pitch in, be a servant leader type, be a good person. I remember one time we had built a really cool model for assisted living dementia care, a building that's I'm still very proud of. Even though we opened it up in 1996, I think it's still, pretty cutting edge. And a guy came along and he wanted to invest a bunch of money with us to build a whole bunch of them. And he took me to lunch and he was saying and doing all the right things. And then he got his salad and there was something wrong with his salad. It's been 30 years ago, so I don't remember what it was. There was something, like he had the wrong dressing, or he asked for no anchovies and there were anchovies, something like that. And so the waiter came over and he just berated this poor kid. It's like, oh my God, this salad, this is not what I ordered, and send it back, and da da da. And that's not the kind of person I want to do business with. So if I hadn't seen him in that setting, who knows? I might have, done. So I just think you need to see people in a variety of settings. As it
That was the
relates
most expensive salad he ever bought.
As it relates to our setting, I've talked with a lot of providers that have been quite successful in having low turnover rates and high levels of retention, et cetera. And so I've seen a lot of people that have good ideas. And so let me just throw this idea out to your listener. This is something that Trilogy does. Trilogy is one of the most successful companies in the space. They've got like 130 buildings, kind of in the Midwest, the eastern part of the Midwest. Even for CNA applications, they have the applicant shadow with one of their workers for 2 hours. So the applicant comes in, they fill out the application to be a CNA, and then they get assigned to a person to walk around and work for 2 hours with them as part of the application process.
So it's not a training, it's pre-consideration.
Exactly.
Interesting.
Trilogy has been around for more than 25 years. They've been completely agency free for those 25 years, except for 2 months during the pandemic where they had to use agency. They have one of the lowest turnover rates in the country, and that's because they have a lot of innovative things. But I think that the shadow thing is very replicable. It doesn't cost a thing to do it, and it's a way, I think, to try to figure out, who might be good or who might be bad. When it comes to leadership positions in your organization, again, unfortunately, I'm not great at that.
I think that's part of your strength, is that you realize what your strengths are and what you're not good at. I think I have that same weakness, so I identify with that.
Yep.
So I imagine the training that you mentioned that Trilogy has also helps for the prospective employee. They say, you know what, let me see what a day on the job is like. Maybe it is not for me. It's not for everybody, that's for sure.
Right. Absolutely. And occasionally they'll have a person that will say, wait a minute, I'm not going to shadow for 2 hours. And you're not, are you going to pay me for doing that? And then they know right away, we don't want to hire this person.
Right.
So it's a brilliant program and it's worked for them quite well.
That's really nice and really helpful. Okay. So jumping in more to ACA, I do want to discuss think on the current events, but I'm curious in a more general standpoint. Your position, in a way, is a bit unique the way we see it, because on the one hand, you understand providers, you're advocating for providers, you're there as their messenger when you're speaking with Congress or whenever you're trying to advocate for the industry. And that is huge. But I'm sure you're also the recipient of concerns that may be brought up, whether they're legitimate or illegitimate or somewhere in between. And you're kind of the liaison where you kind of have to hear what that is and also bring some feedback back to providers. Do you find yourself as representing providers and just fighting the fight? And how do you deal with that challenge of getting the feedback and making sure, if it's legitimate, to address it with providers, if it's illegitimate, to go and make Congress understand, obviously, where they may be not getting it right?
Well, I mean, one of the biggest challenges, but it's also one of the things that makes my job so fun, is that we have such a cross-section of providers that we represent. We represent a total of 15,000 buildings. That's skilled nursing and assisted living. Obviously, we represent people in every single state. We represent for-profit, not-for-profit, single building owners, all the way up to our largest member, which is Ensign, who now has over 300 buildings. We represent people that have a broad amount of differences in experience. Some people that have just, gotten into the business for the first time in the last couple of years, other people where they're fourth generation. We represent people that are incredibly skilled on the clinical side, and then we represent people that are facing a lot of challenges. Our job, and it's what makes it really hard, is we got to make this work for everybody. The board doesn't say, hey, Mark, we want you to go out and help create a system where the top 25% can really flourish. That's not our assignment. Our assignment is to go out and try to make this work for everybody. So part of what we do is that we try to help members that need to get better. We try to help them to get better. So we have a robust quality division within AHCA with a really mature quality award program where hundreds and over time, thousands of buildings have gone through it to get better. But my view is that 95% of our members really want to do the right thing and really want to get better. And even those that are struggling, we can meet them and help them improve. Congress and CMS, by and large, don't know what we do in our buildings. There are very few people, unfortunately, even over at CMS that have actually worked in buildings and have any real knowledge of how hard this is. And so they are not usually right. When they're criticizing us, they're kind of throwing darts. They're hearing about one or two negative things that have occurred in isolated situations, and they're throwing kind of things at the wall to see what will stick and what won't stick. So I don't very often find myself when we get a criticism from Congress thinking, oh, you know what? They're probably right about that. That's not usually the situation. The situation usually is they don't know, they don't have the full understanding of the facts. Some of them care about that and we can educate them. Others are just view us as a political tool to utilize. But our job is to overcome all of that. And we can overcome all of that. We can overcome uninformed politicians. We can overcome politicians that are politically motivated. We have a great story to tell. We have many incredible providers. We have a lot of support up on the Hill. So there are a lot of folks up on the Hill that like us. We have more support at CMS and HHS than people realize. So it's very, very hard. And there's always something coming from some direction or another, but it's also manageable. And I feel confident that the sector is going to be able to continue to navigate through all these challenges.
Amazing. I think it's so important for people to hear that that's really the case. You're seeing it from such a big picture view and realizing that there are so many good providers out there, and there is, a misunderstanding sometimes that they in the government may not understand, and you're really there showing them, if they're interested, to understand it. I'm curious if you found challenges at all with unifying. You mentioned there's all different type of provider sizes and provider types. Getting everybody to understand that it's worth it to kind of band together for the greater good instead of looking out for possibly, your own groups or your own portfolio's best interests. Has that been a challenge, and how did you deal with that?
Yeah, that was the biggest challenge when I came to DC. There were two very active associations that were very active both politically and in lobbying. There was AHCA, and then there was a thing called the Alliance. The Alliance was the 16 largest providers in the space, and they left AHCA like in the year 2000. And I came along in 2011. And by 2011, these two organizations were fighting with each other. And even though on the surface it looked they would try to get along, they weren't really getting along. So we spent a couple of years, and by 2013 or so, we were able to merge AHCA and the Alliance together. Once that merger occurred, our success rate went way up. Our political influence went way up, and we've been on a pretty good string of success for the last 10 or 12 years. I think there's a really good understanding now in the sector that it's better to be united. People have seen what's happened with the merger of AHCA and the Alliance. At the state level, when you look at the states where there's one voice and everybody's a member of the association, those are the states that do really well. The Medicaid rates tend to be higher. The regulatory environment tends to be better. If you look at the states where there's multiple associations and people are fighting and not getting along, those are the states that things don't really go well. So for the most part, the sector is united. And I know that a number of your listeners are part of the ambassador group, and that's just an example of what can happen when people work together. We've had such a great relationship with the ambassador group, with JJ and Jack and Haim and Mark Berger and David Hartman and Norman Rakesh, and I could go on and on and on. And we've all just said, hey, we need to do this together, and we've done it together, and we've gotten really, really good results. So I hope that one of the things that happens when I leave is that people continue to say, even when don't feel like we're getting along right now, what can we do to get along? Because we're going to get such better results if we do.
It's so important. And thank you for mentioning that. And I'm sure all the people that you gave shout outs to appreciate that too, because they are doing hard work, and it's really special. Speaking of unifying all providers, I know one of the really important topics, it's in the news now, and it's something that ACA is really trailblazing the idea of trying to figure out how to deal with this, is CMS's staff minimum mandates, which, as much as I try to wrap my head around it as an individual, it doesn't make any sense on the timing and what's going on with regard to staff shortages, that now is a time where the government is trying to somehow increase care by making these mandates, but they're effectively going to cause some facilities to shut down or limit the amount of patients and residents they can service, which is going to decrease care. How come CMS is putting this in place now, and what in the world can we do to try to change the trajectory here?
Well, it's a great question. And I would answer it by first of all saying, I think that we're eventually going to be fine on this. I completely understand the major concern. It is not possible to implement the rule. It does not make sense to have a nationwide minimum staffing rule, because we have 50, if you count DC, we have 51 different state Medicaid systems. And so we have states where the Medicaid rate continues to be under $200. We now have states where the Medicaid rate is over $500, and to have the same staffing requirement in each of those states is ridiculous. There are also differences in the states about who you can take care of. Some are very deep into behavioral, others aren't. I mean, the states are very, very different. Every administration during the time that I've been in DC has looked at this issue and has said, it doesn't make sense, we're not going to do this, until the Biden group. And unfortunately, with the Biden group, they didn't study it first. They announced it, and then they studied it. And once they studied it, I think they figured out it wasn't a good idea. But by then, they were too far down the tracks. The president had already come out and said, oh, we're going to do this, and it's really, really hard to pull that back. We have still three ways, almost four, to manage this. So I don't want to tell people not to worry about it, but I'm pretty sure that one of these ways is going to work. The most likely way that we'll succeed with this is with our lawsuit. And the theory is quite simple. The amount of nursing hours that we're supposed to have every day are set in a statute. They are not a reg from CMS. They are a federal law that Congress passed. A regulatory agency does not have the power to amend a federal law. Only Congress does. Now, they tried to get Congress to do it in 2021 and 2022, and Congress said, no, we're not changing the law. The administration said, okay, we'll just do it on our own. That is not the way our system works. So we have filed a lawsuit. It's in the 5th District in Texas, the Northern District in Texas, I'm sorry, the 5th Circuit. And we will get an opinion on that towards the end of this year or early next year. I think there's a pretty darn good chance that we will win with the lawsuit. If we don't win with the lawsuit— Is there a reason
you chose Texas?
Texas is a state that is highly underfunded with Medicaid. It arguably, and it depends on what you count, but it arguably has the lowest Medicaid rate in the country. So we think it really sticks out as an example of why this policy makes no sense. If this policy were actually implemented and enforced in Texas, because the Medicaid rate is so low, no building could meet it. There are a few private pay buildings in Texas that could probably meet it, but a normal nursing home in Texas cannot meet this. And so that's one of the reasons that we filed in Texas, and we feel good about that as a venue. Assuming that doesn't work, plans B and C involve Congress. So even with the current Congress, and it's split right now, the Democrats have control of the Senate, the Republicans have control of the House. We think there's a chance that even with this current Congress, we might be able to get some relief. If we're wrong about that and we lose the lawsuit, we'll see what the next Congress looks like. And that might provide us an opportunity to get relief. And then the last scenario, it has to do with the presidential election. Based on discussions that we've had with people in the Trump world and the Trump campaign, we think there's a reasonably good chance that if President Trump was elected to be president again, that this problem would also look quite different to us. So it's a problem. If it was ever implemented, it would be a massive issue. But I think we have it under control, and I think we'll eventually succeed with it.
That's really relieving to hear, and I'm sure everybody's really relieved to know that there are so many different avenues that you feel could really help. Because you mentioned the 7 Habits of Highly Effective People as Stephen Covey's book, I know one of those habits are, I'm not quoting it exactly, but you need to understand the other person's perspective in order to really have a dialogue with them. I'm curious, what is the other perspective there in regards to if they make these mandates and they make these minimums, how do they feel that it's actually going to, how are they going to deal with the staffing challenges that are currently going on? Is there a method? I know there was something mentioned about them funding nursing school to get more people through the door. Any of those avenues actually practical?
Well, and you're right about Stephen Covey. He has the principle of understand and then seek to be understood, which I think is a beautiful leadership lesson. And the whole notion of listening. And you're right, you do have to figure out where people are coming from. So when you apply that analysis to this, they are not coming at this from a policy perspective. They are not sitting there saying, oh, you know what, we think that this could work and that they'll be able to find the nurses and that care will get better. That's not it. This is politics. So the view in the Biden world is that the SEIU was extremely important in getting him elected president in 2020. And they're right. The SEIU was really important, particularly in states like Nevada. And they want to do something for the SEIU. They were unable to deliver on the main ask that the SEIU had, which was $150 billion to be spent on home care, and they got zero. So I think they were looking for something to do for the SEIU, and they decided to do this. Why the SEIU wants this is still a mystery to me. It doesn't help the buildings that they're organized in. It just makes it harder for those buildings to function. I think they think that this will force us to go arm in arm with them to governors and get more Medicaid money, and then the quid pro quo would be that we would open up more of our buildings to union membership. But this is not a serious policy document. There's no serious policy person that believes that we can do this. They know that the nursing shortage is there. They know that this isn't paid for, et cetera, et cetera. This is where they're coming from is not policy. They're coming from a political perspective. I think that many in the administration that do understand this hope we win our lawsuit because they know they'll have a mess on their hands if we don't.
That's very, very interesting. It's so insightful to know what's going on behind the scenes there. So that's really helpful for everybody to understand. Okay, I want to talk about, obviously, the elephant in the room is the fact that we have just until January 15th before you're leaving as your position as the president of ACA. Obviously, although you'll be leaving, everything that you've put in place is going to continue. And I'm curious, being that by next ECAP, you'll no longer be in that position. So let's make believe this is your podium. And if you can just give a little bit of what your vision is for our industry, what direction it's going in, and maybe some pitfalls that people can be more wary of in order to make sure that they're going in the right direction.
Sure. Well, and I think people know me long enough to know that I'm not just a crazy optimist. I try to be realistic, and when things aren't going well, I let people know that. I have to say, and it depends on what state you're in, and this is a state by state thing. But in general, things are going quite well right now, and if you're in the right states, things are going very, very well. On top of that, when you look at the demographics, we are finally at a point where a whole bunch of people are turning 80 to 85. as we sit here today, Steve, there are 8 million people that are between the age of 80 and 85. By 2030, there'll be 10.5 million.
Silver tsunami.
By 2040, there'll be over 13.5 million. At the same time, there won't be any new nursing home beds. The number of nursing home beds is slowly declining. So I think that census will improve dramatically. Now, there are, in my mind, two things that providers have to get really good at over the next 10 or 15 years. One is they have to be world-class employers, because the number of workers, as bad as it is right now, it's going to get worse. Even though the older population is increasing, the younger population is staying stagnant or declining. Providers that get super good at employee engagement and satisfaction and at retention are going to crush it. If you don't get good at that, you're going to have a real problem. The second thing that providers have to get really good at is just overall clinical care. And I think the best measure of that is your hospitalization rate. If you can keep your hospitalization rate low, you will be able to succeed in any risk-based program, whether it's an ISNP or an ACO or a PACE program or the value-based purchase programs that states are starting to develop. So, if I was going to be operating for the next 15 years, I would be trying to figure out, how do I get great at employee retention and how do I get great at hospitalization? I would look at all of the great opportunities that are developing in ancillaries, whether it's pharmacy, ISNPs, rehab, home health, hospice. The people, not necessarily that you should do all of those things, but you should evaluate whether or not you should do all of those things. But for providers that get really good at those two metrics that I talked about, they're going to crush it in the future.
So on the first metric, which you mentioned, where it's focusing on getting employees and getting good employees, that basically what you're saying is that the supply, because of the amount of seniors that are entering into that stage of their life, is going up, but the demand is going up, I should say, but the supply of staff is going down. So right. That's a real challenge, like you mentioned, in regards to the staffing minimums. That just is very blatant when you think about it, that the demand is going so through the roof, but the supply is going down. And I hope that the solutions that are in place are going to address that. But it's pretty blatant of something that's coming up down the line. Yeah,
but here the opportunity is that the average turnover rate in the United States for CNAs is 57%. That's the average building. There are large numbers of buildings where their turnover rate is less than 20%. And there are large numbers of buildings where their turnover rate is 100%. I think if your turnover rate is over 100%, you're not going to be able to succeed in the future. I think if you're under 20, you're going to crush it. And so I think investments in employee engagement programs, investments in existing employees, I think that's the right strategy.
Very, very well understood. And in regards to your second point, and then after that, we'll move on to a little bit more lighter content.
Okay.
So for your second point, in regards to reducing hospitalizations and really, focusing on that value-based relationship with wherever that payer is, curious, obviously, part of the value-based arrangement is there in order to make sure that the payer is not paying hospital care when they could be paying facility care. Obviously, part of that is bringing a resident down to a lower level of care, such as home care or other levels of care that may not be in the environment of a skilled nursing facility. Is that a concern that providers should have, that, hey, if payers are really focusing on decreasing the inpatient stay and trying to get it to be cheaper and more efficient based on the value-based arrangement, how do we deal with that challenge?
Yeah, it is a concern, and utilization of nursing homes will continue to decline. But I believe that the demand for nursing homes will grow faster than the utilization will decline. The numbers are just so overwhelming that even if a small percentage of people end up staying at home or going home, I think the demand in nursing homes will outweigh that. And then the reason that the rehospitalization rate is so important is that you can succeed in an ISNP or a PACE program or an ACO, but only if you're keeping people from having to go back to a hospital. And that's why I think that people need to be laser focused on that metric.
Amazing. That is very reassuring. And Mark, you seem to have all the answers that we need to make us sleep at night. So on behalf of everybody, firstly, I want to thank you, but we're going to move on. I want to just address for everybody listening, this is going to be a true or false questions. I'm going to ask Mark some true or false questions about himself. And you guys can guess along if you feel it's true or false. Mark does not know what I'm going to ask him. So hopefully you won't get upset at me. But a couple of questions that we prepped based on some homework that we did. So question number 1, true or false? Mark runs a family farm as a way of always keeping himself grounded. Do you run a family farm?
Well, I'm going to guess that most of the listeners are going to think that's true. And the answer is yes, that's true. And I don't actually run it. I don't want to take credit for it. There's 8 of us in the family that own this farm. My grandparents homesteaded this clear back, great-great-grandparents clear back in the 1800s. We have 1,480 acres in Scott City, Kansas. And it's something that we will never sell. And that's kind of just a value that we have. The Parkinsons will own this farm for as long as human beings are running around.
That is amazing. That is really news to everybody, I'm sure. Okay, we're going to move on to the next question. After his retirement, Mark plans on using his government and law background by volunteering for the State Public Defender's Office. True or false?
Ooh, so people know that I'm a lawyer, and they know that, I'm probably a little sympathetic to defendants, but that answer would be false.
Ooh. So what do you plan on doing?
So I'm really gratified. Some folks have reached out to me. So I'll be involved with some providers. I'll probably be involved with some vendor partners. I'm publishing a book along with some folks at ACA in the fall about the very best providers and how they have achieved that. And I may run around the country a little bit and talk about how people have become great providers and what the lessons are from them.
That would be
and
amazing.
Also, I'll spend more time with all the normal stuff. I'll spend more time with our kids, with our grandkids. I don't know if you have any questions about horses, but I'll spend some more time with our horses than I have in the past.
Good for you. It's really good to hear. And it sounds like you have a certain work ethic that you could just keep on going, which you're trying to help. And it's amazing that you're still focused on that at the same time as focusing on your family and everything else that, you'd like to. Next question, next true or false? Mark once ran out of diapers for his daughter and borrowed Depends from a resident after some quick thinking. True or false?
Well, all of your listeners are going to know that one's true, because if you have your kids in a facility long enough, this is going to happen to you. So I don't know how you learned that, but yes, the answer to that is true.
That's awesome. It just again pays tribute to your quick thinking, and it's amazing. Post-pandemic, you intended to retire, but realized the industry needed you, so you extended your position. True or false?
Well, I mean, the extent of my position, I'm not sure if the industry needed me, but that's true. My intent was to retire 2 years ago. I didn't want to retire when I was too old to do anything else. 2 years ago, I would have been 65. Yesterday, I turned 67. So,
happy birthday.
Thank you. So, again, some folks have reached out to me. So apparently, my expiration date hasn't quite come yet. But I was honored to be asked to stay on an extra couple of years. I wanted to make sure that we were completely through the pandemic. Frankly, I wanted to get us through the first Biden term. Whether there'll be another Biden term or not, I don't know. But 2 years ago would not have been the right time for me, and I don't think it would have been the right time for ACA. I think now's the right time.
But if people ask nicely, you might reconsider?
That train has left the station. We're past that.
Got it. And final true or false question. At ECAP 2023, you stood back to back with Shaq to see who was taller. True or false?
Okay, so I think people will probably get this one. That one's false.
Who is
I
taller?
would like to
Not
have
sure.
done that, but that did not occur. Maybe at a future recap.
There we go. Mark, it's really been a pleasure. I really appreciate your time that you gave us, and more than anything, all the information and the learning that we've been able to do. is really invaluable. So let me be the representative to wish you so much luck with wherever you're going to move on to next. And thank you for everything you've done for us in your position for so many years.
Thanks, Steve. It's been great working with you and the providers over the years. This last hour has been wonderful, and I'm not done. I've still got 6 months left with this. Hopefully, we'll have a few more wins before I leave, and I'll be around. And I look forward to seeing you in other settings.
Awesome, Mark. Thanks so much, and thanks to everybody that helped make this happen.